Grounded in research, individually focused, and back at last. Welcome to the Thriving with Stripes podcast.
Okay, welcome back to Thriving with Stripes. This is episode 2. My name's Tom Stott. I'm sitting alongside Dr. Patty Stott. And today we are redefining connective tissues. We're
Yeah.
gonna we're gonna get nerdy and talk about the extracellular matrix.
Yes.
All right, so where do we want to start this thing off? Do we want to go misconceptions about connective tissue issues and then kind of break down into like our schema of how we think about things, or
Let's do that. Let's start with the misconceptions. I don't want to say my pet peeves, but they are. I feel like the I hate to call it an industry, the medical industry, but it is, right? Like our movement
it's a
professionals.
complex.
Yeah, I feel like it's saturated with the idea that hypermobility is the problem. And I think for some people, hypermobility can be a problem, but I think that we're doing a disservice to our patients out there and saying hypermobility is the problem. It's so much more complicated than that. And I think that we try to oversimplify things, perhaps for our patients. I don't know. I don't think it's
We're
helpful.
naturally reductionistic as
You
humans.
can't be reductionist if we're talking about connective tissue disorders, even as physical therapists, where you're like, well, but what I do is movement. Okay, well then, understanding that somebody can have a hypermobile joint, but the problem is actually not the hypermobile joint; it's the fact that the fascial structures around it have become stiff because of systemic inflammation that is more prone to causing problems in this population, and that's why it's now popping out this week
Right.
because hypermobility in and of itself is not necessarily problematic. Yes, it can cause some loose joints, and I'd like to talk about that in another episode where we kind of talk about the different types of joint movement, like hypermobility versus hyperflexibility versus subluxation and dislocations and fixated subluxations and micro instabilities. And it's important to know the difference between all of those as providers, especially. I think patients already experience them, they just don't have words for it.
Mm-hmm. Okay, so some of that is a podcast in and of itself, but in terms of broad misconceptions with connective tissue disorders, that it's just hypermobility, that it's isolated, I would say, to certain systems, that it's not all inclusive of the entire system. But spoiler alert, it is.
It is, and it depends on what that person's genetic risk factors are, right? And this is like we are such babies in the world of genetics and understanding, and the extracellular matrix too, which is why this makes it so complicated, is because our patients have become more complicated, and we haven't caught up with the science yet to be able to educate people on why and why is this happening so rapidly? Why do we have so many people that look like they have EDS? And why do all of those people that have EDS look like they're progressively getting worse each generation? There's a reason for it.
I have a very broad general thought that I've been thinking of in my own brain that I feel I can kind of connect the dots for some people on this. Can we go with this for a second?
Go with it.
So, you know, the person that's like, well, we didn't have all these food allergies when I was a kid. Or
Mm,
I'm not
yeah.
necessarily making them out to sound like a parent, like somebody older than me, but like we didn't know, I didn't used to know so many people that had this or that.
Or autoimmune disorders,
Yeah.
or yeah,
Insert any number of things
yeah.
that we used to not have. And I think that's a great framework in just generally thinking about the extracellular matrix. And maybe this is where we can kind of jump into of you don't have to have hypermobility to have dysregulation in this system. You could be anybody, and our hypermobile populations might just be a little bit more, because of some of these structural differences, might
Right.
be a little bit more subjected to, or, I should say sensitive or reactive to.
Reactive to, or like it's more so that the reactions aren't appropriate or they're not efficient. So this is all in the science. This is not my opinion on things. It's just science about the extracellular matrix. For a while when people ask like, what do you specialize in? And I would say, well, specialize in hypermobility and EDS. And now I say, no, actually, I specialize in connective tissue. That's my specialty, is really understanding outside of even EDS, but some of these other conditions too, right? Like Marfan's and Lloyd-Dietz and this kallikrein component and HAE for some people has to do with the matrix. So it's really more broad than the hypermobility and even EDS, how we define it too. And ballsy, but one day I hope to say that I'm an extracellular matrix specialist. But that's ballsy because that's really complicated. And I think that's where this is a really complicated problem when something happens at the level of the matrix. And depending on, and we can go right into, well, what is it then? What's a connective tissue
Yeah.
disorder? And a connective tissue disorder is something that's dysfunctional, usually genetically in the extracellular matrix. Now, the extracellular matrix is just what makes up our connective tissue. So if we're talking about tendons versus ligaments versus bone versus meningeal tissue, neurological tissue versus the lining that's, at the skin or the lungs, it's just based on the same components, but in different ratios, right? Or different types of collagens. So when we're looking at the extracellular matrix, I look at it like ingredients in a recipe.
Mhm.
And this is where it gets complicated. And knowing one's genetics can be helpful when we know where all of these ingredients are, because we don't. Just so everybody understands that. That's why this is like, we kind of know where these things are, but we don't. But depending on, if we're looking at bone, well, that has a lot of collagen type 1 in it, a lot of collagen type 1. And it not just collagen, there's other proteins and glycoproteins so that go into this, and hyaluronic acid, and just so many different things. But depending on the ratio of all of those, you might be looking at a tendon versus a ligament versus adipose tissue, or the fascial structures. And so what's important that we'll find out at some point is what are somebody's genetic variations or genetic deletions that are putting certain different types of tissue, depending on these recipes, at risk. So if somebody has, a collagen 1A1 or a collagen 1A2, depending on where that is in the body, if there's a variation or a significant deletion, that might cause inefficiency wherever collagen 1 is found. And it's not just bone, it is found in ligaments, and it's found in tendons, and it's found in the dentin of your teeth. It's found in, the optic nerve. It's found in, there is some in meningeal tissue, nervous system tissue. But, the big hubbub, I think, which is where things are going, is it's also found in the interstitium, which is this place where we just thought, oh, it's the in-between, so it doesn't mean anything, right? And every time we've said that in science, we've been wrong.
Like
And
looking up at the sky at night and seeing the stars and being like, the black space is just black.
yeah,
Like maybe
just
there's a
filler.
dark energy or a dark matter there. I'm pretty sure something else is driving the movement of the universe, and we're just not keen to it.
Yeah, so in between all of our tissue spaces, so in between fascia and muscle, in between fascia and an organ, we have the interstitium. And the interstitium, it is the open space. It's supposed to be where things are transported and moved, where cytokine activity happens, where mast cells are receiving messages. This is where things happen on a cellular level. And this space is also supported by it's extracellular matrix. It's just, that's the interstitium. I look at it like we have barrier systems, we have connective tissue as we standard think of it, right? Like connective tissue proper and specialized. And then we have another group, which is the interstitium, which acts more like an organ. And yes, so does the fascia. Like we can argue about all of these, right? But the interstitium is something that we've overlooked for a very long time. And this interstitium is supported by collagen. It is currently right now, and I say this because this is so new in its exploration of what these tissues are made of, and it's not verified over and over in science. So we need to verify this, but it looks like it's made of collagen type 1, 2, 3, 5, and 11. So those that have problems, and this is the structure, right? So this is collagen is the supporting structure for, I think of it as like the scaffolding in skyscrapers. Well, if you think about the interstitium, if your scaffolding is made out of rubber rather than metal and you keep adding people into the skyscraper, eventually the structure isn't going to hold up and those people get squished and they all get stuck in the skyscraper, right? And this
Sure.
is what some of the research by Tina Wang that's been coming out is talking about, the stiffness that develops because of neuroimmune responses that are happening at the level of the fascia. And that's what we're saying, is that, again, it depends on what the person's genetic predisposition is. But if you have a collagen type 1 problem, you might have difficulty maintaining the structure of that interstitium to hold it up in space, to allow everything to function through properly, especially when you add extra things, which is typically cytokine or inflammatory activity, which bogs up the place. And then now, if you just leave that, if that's all that's happening, collagen dysfunction, lots of inflammation by itself, eventually, if the inflammation isn't taken care of, then systemically, not just locally, which there are some papers talking about local fascial dysfunction. Brian Tuckey has talked about the lymphatic pump shutting down. And yes, that's what happens, but that can happen locally for an injury, right? And a fascial restriction. And that's why the shoulder's popping out more. It's because it's hypermobile and the fascia's gotten tight. But it happens systemically because the interstitium is an organ that talks to itself throughout the entirety of the body. And this is what I need people to understand, is the systemic response that can happen, especially if we have interstitial components that are genetically affected as a risk factor in an individual, because those people might have more difficulty dealing with inflammation. And if nobody's taught them for decades, however old they might be, it builds up over time. And at some point, you have the whole story of the straw that broke the camel's back of, well, now
That was
you're
good until
it was like kind of hanging on until the lymphatic pump shut down, and now you're stuck in this self-perpetuating cycle of inflammation, and stiffness develops because we don't have a good plumbing system. And the plumbing system is different genetics. The plumbing system are these detox pathways or things related to lymphatics, right? So that's where genetics create a story. Autoimmune disorders, I know that they're starting to do some research on this, the crossover between autoimmune and connective tissue disorders. Well, it's kind of the same conversation when we talk about the interstitium. This in between space is that when we have an autoimmune disorder, that's an abnormal inflammatory response from the immune system, which, guess what, goes right into the interstitial space. So that's like, if we're talking about that interstitial space, you could have a risk factor of the structural space itself. The autoimmune part of it is that your genes are more likely to turn on a fire hose of inflammation rather than a little trickle. So that's not helpful either, right? And it's, again, more likely you're going to have these chronic inflammatory loads that are difficult to plumb out. And a lot of people are actually missing these genetics for the plumbing piece of some of the detox pathways that we have. Again, there's lymphatics involved. Yes, there's mitochondrial health, but I think that's why it's important eventually knowing somebody's kind of full genome that they're presenting with, and not to diagnose somebody and stamp all these labels on, but to say, oh, okay, I think we can figure out how to support you and
sure.
in what order.
I think it's validating in regard to the age-old question of that's on all the message boards, that's just a hot topic ticket by the time people make it into this office, is like, why are things progressing so badly? And
Yeah.
it's for
Well,
that exact picture that you just painted there of, it's not that it's just it's a fire hose of inflammation that's uncontrolled.
and
It's not assisted.
it's
Yeah.
poorly managed within these connective tissue spaces. And I know I talk about the interstitium a lot because that's what I see, right? And this interstitial problem, or this, whether you call it like interfascial stiffness or the in-between spaces as they get sticky, can happen in different tissue structures. It's not just fascia around the muscles. Thank you, Tina Wang, for showing the recent one on adipose tissue. Now, can we talk about meningeal tissue and where tethered cord is coming from for the majority of people that have connective tissue disorders, and why there's such a high risk for retethering is because this is a systemic condition, and because of other predispositions we have, like abnormal spinal movement, and yes, maybe some pre-existing injuries that somebody has. The hotspots for neurological irritation are at the upper cervical spine and the lower part of the cord itself at the phylum. They're hotspots for pressure reactions. When you add systemic inflammation, that's bunging up the meningeal tissue, and you don't have good neurovascular plumbing. So this is let's not be reductionistic and say, oh, this is a phylum problem right here.
I'm just laughing to myself now because I'm thinking like, okay, you have somebody that's walking from their car into an appointment and they hit a rock in the parking lot and roll their ankle. They sprain their ankle.
Is that my story?
I mean, maybe that's hitting a little bit too close to home. Like,
I can do crazy things in martial arts. I can't get myself into the office.
From a store.
I know, it's EDS.
And so that situation happens in this hypothetical. It's a hypothetical. So this happens and your ankle swells up. And you're like, oh, that's from an injury in the parking lot.
Mhm.
And now we're talking about having symptoms of like cord, we'll just call it cord tethering, right? And we're like, oh, it's definitely right there. But let me like flip it and be like, what if you just woke up one morning and nothing happened and your ankle was swollen? Immediately, most people would be like, huh, that's a little bit weird. I need to think bigger picture, even if they don't know where to start.
Right.
And here we're having people seemingly just wake up with issues and we're immediately being like, oh, no, it's definitely right there where the issue is.
Right.
And it's almost like, what?
And that's where the hot spot is. Like, that's what I tell people, and we talk about tethered cord in another podcast, but I tell people it does sound like I hyper focus on inflammation, but the reason why I do is because not enough people are preaching about it. And this is where the retethering will come from, is if we haven't managed the neurological inflammatory reactions at the level of the connective tissue, you have helped the local hotspot, but you have not necessarily changed what's happening at the rest of the neurological tissue in the body. And this is where, you can see some research coming out now that's talking about this spinal tension syndrome, and that people with hypermobility have more lax spinal cords. And that's the problem. And that's why they end up with tethered cord. Well, yes. And it is like we stretch more, but our body doesn't like it. I mean, that's kind of the story of the life of EDS, right? But it's actually the reaction to the stressor is that it has the ability to stretch more, but the response to the stretch is abnormal. And when you add inflammation on top of that, that's where pathology comes from. Because if not everybody with hypermobile EDS would have tethered cord.
Right.
And they do not. In my office, we talked about this in the first episode of like, I see a lot of the patients that have neurological phenotypes. It seems like in my office, it's like 50 to 70%, but that's just because I tend to see the people that have not been helped elsewhere. And I do believe that it's because of whatever genetics or whatever they've been exposed to, is that their body has gotten into the situation of this systemic reaction of like whole body connective tissue health shifting. And unless you work on that, you can keep doing all the local procedures you want. And I've talked to people too, like, I'm not anti-surgery. I'm surgery at the right time, because also the timeline I'm talking about this is years of working on connective tissue health. This is a slow process. And for people in the neurological category, we usually have to do a lot of neurological retraining, which is also slow in and of itself. So this is a very long process, and my timeline might not match the health of somebody with their symptoms. So yeah, surgical procedures might be necessary, but how do we start to limit, for those that are more savvy to this EDS world, some of those options that we have for people are getting 2, 3, 4 to 6 procedures done over and over again to try to, help stabilize. And that's why I'm just trying to get this message out of, I'm not anti-surgery, but if you'd like to have more precise treatment, we have to recognize that the connective tissue as a whole might be changing. And this meningeal piece, this is why I said stay tuned, because I don't have all the information. In fact, they just did it was 2023 that somebody was like, hey, how come we don't know exactly what meningeal tissue is made of? So I'm talking about the dura, the arachnoid, and the pia mater. They didn't know what the extracellular matrix components were. Well, don't you think that's important for like people with connective tissue disorders, so that
do?
Yeah. So that we don't.
I didn't even know that I didn't.
Right.
I need to know that.
That's the problem, right? And just to branch off a little bit, as we're talking about like barriers and interstitium and connective tissue. And so the meningeal tissue, the neurological tissue, is actually a lot of collagen type 2, which is considered more of like a skeletal dysplasia or cartilage type of problem. But there's a ton of other types of collagen that are in there. And even they said, they're like, yeah, but this is the first study. We need this repeated over and over. There's collagen types 4, which I'll talk about in a minute. There's collagens type 6. There's collagens, which is more of like what we consider myopathy disorders. Collagen type 4, we don't even currently classify as connective tissue disorders. But there is collagen type 1, there's collagen type 5. There's a ton of stuff in meningeal tissue. So somebody might be more prone to dysfunctions of the extracellular matrix of the neurological tissue depending on their genetics. That's why I like to be more precise with individuals. But to continue my rant, I'm not always this ranty, but I love the extracellular matrix, and I don't think we've given it enough credit, especially when we're talking about genetics, because collagen type 4 is not considered a connective tissue disorder. You won't get any of this feedback on genetic panels, which we should talk about too. But collagen type 4 is considered a kidney type of disorder. Well, collagen type 4 is still collagen, and it still makes up part of our extracellular matrix. It's just more of a barrier system. And not only that, but like barrier system for the lungs, barrier system, like these protective layers that's supposed to protect these tissues from pathogens breaking through. This is like the membrane systems. So skin as well, and then blood-brain barrier. So these barrier systems are really important. So yes, somebody cannot have a collagen type 4 problem, and after a while, just chronic inflammation around the barrier systems can break it down, right? But you'd be more prone to the blood-brain barrier potentially breaking down or these other barrier systems if you had something going on genetically that affected the efficiency of collagen type 4, which we don't talk about unless you look at the articles on COVID and extracellular matrix, not connective tissue disorders, but for years they've said, hey, like there's something going on with the extracellular, like the health of the extracellular matrix determines how somebody responds to COVID. And I just heard a little birdie told me that there is a COVID and EDS article coming out. Great. I'm so excited to read that. And it's been in the literature regarding specifically collagen type 4 and long-term lung issues in COVID because it's connective tissue. So there's different things to look at in the human body that I think that we're ignoring. And because we want to listen, okay, what's your symptoms? I'm just going to focus there, just right there, and not think about where this might be coming from.
Yeah, I think there's, excuse me, a lot of almost like good ammunition that doing this work in the ECM can kind of offer people if you're willing to learn and listen. And it's a space where it both seems like, how would I ever treat this if it's everything? And if I start to know some pieces of this puzzle, like from a genetic sequencing and some of the symptoms and where this is at in the ECM, it starts to lead yourself down a roadmap if you're willing to say, like, I might not have the answers right now to help you, but we'll keep gathering information and see what's along the way. I think one of the tougher sells on just this approach is that it is, it's that age old thing. What if I told you that you could feel better, but it's going to be a lot of work and I can't tell you how long it will take? Would you be down to go this journey with me?
And I don't know how much it will fix.
Right.
Right. So it's the case of only two options when you're dealing with chronic illness. And that's what I tell my patients. I will support you in whichever one you want to do. I just want you to understand that there are two options and neither one of them is easier than the other. You can continue to do what you're currently doing, which if you end up in somebody's office, it means that something is not serving, right? Like something needs to change. You can keep doing that. And that's really hard because if it's not working, then things can continue to look progressive, right? So that's not great. Also, if you take this other route where it's literally like the biggest blind trust fall of your life that's off a cliff and lasts who knows how long, but maybe there's somebody at the bottom to catch you. And maybe it works. Maybe you still will need procedures, but maybe just want like that's also really difficult, right? And it's a lot of that's a lot of things put on the patient of especially when we're talking about connective tissue health. Nope, it's a lot of things for you to do. There's no easy option, right? There with the idea of working on connective tissue health or trying different things for it, at least we can try something and move on. That's also where I think some providers get stuck is they're like, well, no, let's keep doing it. And I'm like, no, we've tried it. Let's move
Yeah.
on. Let's do something else.
Yeah, like it's a
Um,
window. We gave it a targeted approach. This tactic is not working. We need a new tactic.
yeah, regarding connective tissue health, not like, it
Overall
just it
approaches to things. Yeah.
yeah, looking at overall health, it takes a long time to work through things. So it's really hard to give like the two options are do nothing and you're probably going to feel worse, or do lots of things that are going to make you exhausted, and some of them won't work and it's going to be frustrating and you're going to have ups and downs, and I don't know how much you're going to get better, but there's the potential for it. That's there Neither one of them is great, but at least one, like I said, gives you the potential for some improvement.
Yeah. I love
So
donkeys. This is going to sound like a ADHD side quest, but I'm going to bring it back.
okay.
I do love donkeys, and donkeys tend to be a little stubborn
Uh-huh.
at times. And I see systems having been alongside your journey and part of it for a long time now, where like you and I both know this is this is a good thing for me. I know it's good, and I just need it. I need some bit of it to help, and it doesn't.
Mhm.
And I think sometimes we meet systems where there's so much complexity that the system comes off as being stubborn. It's like a donkey, and it just won't, like, I'm guiding you to the water, drink the water, and you just can't get it to. And that's where,
Yeah.
like you said, you need to be able to pivot and move on to something else or shift and like, hey, we'll table that for now,
Yeah.
keep that in our apothecary of goodies, and maybe it's something that we can come back to.
Yeah, and please protest and take breaks, and this like it's a long journey. My own journey of healing, of slowly and progressively getting better with lots and ups and downs has probably been about the past like 3 years, I'd say more significantly.
I mean, let's just call you out right now. What are you holding in your hand?
Okay, let's call me out. What did you call it?
It's Queeze Ease. It's like a,
Queeze ease.
yeah. I mean, not a product plug. A
No.
patient told me about it.
Yeah,
But just,
thank you, by the way. It's just one of those days, right? I woke up and I was like, oh, I don't feel so bad. And we got in here and I was like, oh gosh, how like I usually don't have bad high pressure days when it's high pressure outside. This is a weird wonky day. So yeah, it's constant, right? Like it's constantly trying to figure out how to live with a body that has a different structure to it and interacts differently with the environment. And that's literally what it comes down to.
yeah. And one of the ways that I describe kind of what you do is almost like quarterback and kind of guide. Like you accepted probably just about a year ago, not that long ago, that you can't learn everything, all the skills. Like you were like, I should probably, the couple things I'm like, I feel connected to, I should probably just keep strengthening those skills.
Yeah.
Let me not go learn 50 new things, maybe like 45. But, and in doing that, I think you gave your brain like the ability to kind of focus in and like not have to worry about everything.
Hmm.
Um, I lost where I was going with that.
Yeah. Stubbornness, bodies, donkeys, queasies.
Yeah.
But yeah, coming back to like just the connective tissue journey, there's a lot to work on, right? And as we're talking about all of these, like down at the level of the connective tissue and inflammatory responses, the question is always, where did your inflammation come from? And that's where you cannot assume anything. Now, yes, I usually like wave my finger at inflammation, but where is that person's inflammation coming from? And the person might not even know. The person might know exactly too. They might say, yes, this was COVID or Epstein Barr or mono or whatever it might be. Or no, actually, but what you're saying, like every time I had a flare up, it was associated with like couple weeks after a virus or stress or whatever it might be. It's inflammation is the problem. The reason why somebody has inflammation is dependent on the person.
Sure.
However, and this is why like everybody is individual and unique. However, when we're talking about this connective tissue disorder, the connective tissue, because of this interstitial space and the role of connective tissue, it acts as a filter system for the body. So when we're talking about inflammation, we're talking about all of it. We're not hyper focusing because it's the structure itself, it's the filter. It's not necessarily big bad mold. We've all been exposed to all of these things at some point, right? We're giant petri dishes. But those that have connective tissue disorders, just like we're talking about the gut, we have difficulties maintaining and stabilizing the microbiome of our connective tissue, of the petri dish. Like we get overloaded with certain things. So that's where like we have been exposed to everything by this point. We really have. But that's also why now can you understand if inflammation is one of the driving forces of setting somebody's connective tissue off, why we have been, looking like we're getting worse generation by generation. And especially now with all the viral exposures and you can't escape mold. Sorry, like you can work on it, but you can't escape it. And like, so a lot of times our food sources aren't great and there's just so much inflammation and chronic stress. Oh my gosh, chronic stress is also an internal inflammatory response that happens, goes right into the interstitium. So it's the filter that's a problem, but it's all of the things. So that's why I say it takes so long to work on, because I need to teach somebody. I don't want to just treat you for post COVID. I don't want to give you the herbal remedies and say, okay, have a nice day. You never have to worry about this again. I can't prevent what's going to happen to
Right.
somebody's connective tissue. I want you to learn that if you feel, because this is a microbiome and viruses are nasty little buggers, they will hide and play dead. We don't really think that we can fully kill them off. Again, it's a microbiome. Can we teach somebody how to recognize if something's more of a viral versus bacterial versus heavy metal versus mold type of flare to be able to treat it? Practitioners who hyper focus on, no, it's mold in EDS, and no, it's Lyme in EDS, and there are some catalysts out there, right? Like the catalyst to a chemical equation of connective tissue it does seem to be viruses and mold. However, there are other parts of that equation that might be somebody's primary problem, if that makes sense, right? So somebody's primary problem might actually be, heck, it might be an injury that they had to T8. I saw that one yesterday. We're working on it. But these other parts of it are catalysts, and you're not going to get T8 to feel better until we go through these other inflammatory drivers that's making it difficult for your connective tissue to restabilize. So, and then there's people that talk about, yeah, but when I got sick, it was the mold. Okay, yes, but that's what overflowed your bucket. It had been filling with viruses, you told me before. So you can't point your finger at any one thing besides inflammation in general. It's just looking at, okay, how do I teach you what you need for mold, for connective
Right.
tissue? How do I teach you what you need for like mitochondrial repair afterwards? So that's why we can't. If it sounds complicated, good.
Yeah.
Learn how to treat complicated.
Yeah. Okay. So two things. One, I remembered it, but I'll
Okay.
come back to that. Two, it's what you just said about, yeah, it was all these things, but it wasn't until this happened that, I really I just couldn't handle things.
Mhm.
And that would be kind of like, I talked about quarterback earlier, so we'll stay in the American football piece. The kicker misses the field goal in the last final seconds. You don't blame the kicker for losing the game. Sure, somebody's like, oh, freaking the kicker,
Lots
but
of people do, right?
yeah, and we need to look back though, well,
It's
we
the
had
whole
two
rest of the
fumbles,
game.
you threw an interception, we should have scored, just instead of settling for field goals or whatever in the red zone. You could just go about it and be like, it's all 60 minutes of the game,
Mhm.
not just the final 3 seconds that we need to consider. Ooh, that's a good
Mhm.
one. But back to what I was saying earlier about, I describe you as a quarterback, and the way being able to see the field and appropriately decide, all right, this is what we're going to do first. That's how I describe your role in the clinic. And one of the things I'm thinking about now, though, in a case where you've described hey, I've had some really low periods and I'm kind of crawling out of this 7-year hole and having a bad day today. It's kind of like you yourself are the quarterback in a game that's just not ending. Like you've had a
Yeah.
couple half times and, in this hypothetical world, but you're in like the 12th overtime. You're like, this game just needs to end so I can start fresh.
Mhm.
And I think that's what most of our providers that have some of these issues and our patients are looking for is some like switch to flick where, all right, I kind of got a fresh game in front of me. Let's
Mhm.
restart.
Yeah. Yeah.
So we do that through the ECM and it's slow because the extracellular matrix is this big crossroad between cellular level, interstitial, nervous system, vasculature, blood, immunology, mass, like all of these things are at play. And this is where you realize, oh wow, that is a lot. That's where I kind of think one of your superpowers is to saying, hey, I have all these things. This is where I'm going to start.
Yeah, and it might be different person to person. That's what like I'm not going to give you the key to treat connective tissue on this podcast. It's like it's impossible rather than
Right.
saying look at it as the whole picture of the extracellular matrix and then figure out why somebody's extracellular matrix is mad, which might involve genetic components. But genetics don't always 100% define us. They can guide a story, but it's the same thing as like autoimmune, like other genetics that we have, and it came up in my yoga class the other day. Like, why did everybody in this woman's family have diabetes at the age of 30 and she's 67 and just being tested for abnormal numbers? Well, there's a genetic risk component, and then other things contribute to turning those genes on or, more expression of those genes. So that's where, like, I think that we do have more control over connective tissue disorder presentations than we think. It's just that we've tried to put it in this narrow box of hypermobility, and hypermobility is a sign. So, in other words, like it's a sign that there might be an underlying condition. And hypermobility might be a problem for some people. But and yes, there's might be increased risk for like orthopedic injuries, but this the brain fog and the ME and the chronic fatigue and the gut disorders and the neurological phenotype near and dear to my heart, like all of these things, vascular compressions, same idea of what's happening at the blood vessels systemically. It's connective tissue, guys. So when you change systemically the connective tissue around blood vessels, it can lead to multiple vascular compression sites because of reactivity. So, and that's why there's an article out there that says, like, hey, all these people have pretty significant mast cell activation syndrome that have multiple vascular compressions. Yes, because inflammation is driving a systemic connective tissue change. And until you work on that, we don't want to chase things, right? Like we want to try to minimize surgery.
Stent.
Stents are hard to get out, guys. They're that's why like and I have had some people that do need them. That's why I'm not anti-surgery, because the timeline did not match where that patient or patients, actually a couple, were in their health journey. And one of them absolutely said like they had May Turner syndrome. Like, but our population like kind of has it, but they don't, right? Like we like it's kind of tethered cord, but it's a little bit different, or it's kind of like May Turner, but we're not seeing the exact symptoms. And it's because there's risk factors, right? But it really is the inflammatory response at the level of the connective tissue that is feeding this.
Well, everything I think is a spectrum too. And this is not like totally related, but like in a bell curve. And like when you talk about your patient that why are we just testing and even looking at numbers when they're 67, when there's a significant family history and acquiring of like diabetic, or what I was going to say was diabetic like things at 30? Why aren't we looking sooner? Like it's
Right.
this old medical thought of wait till they fall within the standardized part of the bell curve with now we need to treat.
Right.
And if we think about it, like before we get diagnosed with like May Thurner, what about May Thurner like symptoms? And we're
Right.
starting to get some of these vascular things. If we
Right.
just slap that dash like next to everything and just consider everything as a spectrum, it might give people a little bit more permission, if you will, to be like, hey, big scary diagnosis, but what are some things I can start doing,
Right.
you know,
That's what I tell people too in my clinic. I'm like, we might start talking sooner rather than later about some of the big scary diagnoses that you might have heard about, but I will always talk about it in this calm voice because there's usually a lot that we can do for it. There's usually a lot, and that people get excited until they go home and it sinks in and they're like, oh, I don't know if I have the energy for a lot. That's what, like, I want to be realistic about all of this.
Right.
It is exhausting and tiring.
All right. So what else do we need to cover with, go ahead.
Genetics. So
Genetics,
I
okay.
do want to just probably the last thing that we can kind of talk
Yeah.
about, and we can brush up this topic, right? I'm sure that there's going to be new stuff coming out over the course of the next few years, but I want to talk about genetics because, and I've had wonderful, wonderful geneticists that I just adore that have told my patients that they do not have any variants of unknown significance. Their genetics are all normal within the connective tissue panel, because they have run, and I'm not going to name because I don't want to point fingers, because they have run the tests that everybody has heard about. Right. So the one that our geneticists are currently using, that, and I think you can get it covered by insurance. That's why I'm like, heck yeah, like, let's get things covered by insurance, because unfortunately, I feel like in this world, a lot of what works for people or is helpful for people is really becoming out of pocket. So sure, go get that test done. What that test is exon sequencing. So about 80% of human disease is found on exons. That's cool, but we haven't found hypermobile EDS. And if 20% is on introns, and this company and multiple other companies too, right? It's not just them, are only testing on exons because we think that's where most hang out. We're actually not getting full data. Also, I don't know if it also reports genetic deletions. Even genetic deletions, you have to look up on your own on full genome sequencing when you have it done on the commercial market. Variants of unknown significance, that just means that we don't know. It does not mean it doesn't mean anything. It just means actually we don't know, because when you look at like the COL1A1 gene, people think, oh, COL1A1 gene, I have a pair of allele. No, it's like 1,800 different pairs to go through and locations on the gene. This is more complicated. That's what, don't be reductionistic. This is really complicated. Just because one test came back and said there's nothing wrong with the genes that we tested for, it doesn't mean that you might have a variant of unknown significance or a deletion that we might find out one day. Actually does mean something. So that's why a lot of people are having full genome sequencing done, because that's not going to change. Your genome doesn't change, like your full genome, introns and exons. That data is going to stay where it is. It's the research around it that's going to change, where one day they might be like, oh my gosh, hey, we just found, hey, that variant of unknown significance on your COL1A1, that is what we're finding in people consistently. Some of them might have more minimum related like coding properties, but some of them might be more significant. So if you just happen to have the deletion or the variation in a more significant part of that gene, it might affect you more. We just don't know yet. There's this is really complicated. It's not as simple as we think. So
Kind of analogous to the introns, to the black space in the
yeah.
sky and the interstitium, like.
Yeah, it's all, we keep saying that, like, oh, we know what we talk about. I tell my patients all the time, trust me, I have no idea what we're talking about, because we actually know so little of what we're talking about. We know so little. We're trying to talk about genes, but we haven't explored the depth of what all of these mean, what introns actually mean. If you have an intron deletion, does it affect the exons in the way that, yeah, it might. Actually, they're finding that. There's a article on COL1A1 that was an intron variant on 2 fetuses that was actually significantly affected. So we're getting there. It's just really slow. So I challenge providers to say, I don't know. Or, like, if we're talking about genetics, is currently the testing that we have available and the cross-referencing of data is not matching anything that we currently have. It doesn't mean that you don't have a connective tissue disorder. Do you know how many different, oh my gosh, the Matrazone project, we didn't talk about this. Like I said, like, people didn't look into what connective tissue is made of. So there's a project that started, and there's articles out there like this, I said, the meningeal article that started to put it together. And we're like, hey, maybe we want to know where collagen 9 is. That's a funky one that I've seen with some presentations in my office. We thought collagen 9 was like not a big deal, but maybe, I don't know. So the Matrazone project is out there trying to put it together of not only these structural components, so like collagen and the different structural components of the extracellular matrix, but also the functional components, which we didn't really talk about today. But there are functional components of the extracellular matrix, like different genes that code enzymes, or like we have the transforming growth factor, or like the kallikrein gene. And those things can affect the breakdown of the matrix. So it's not necessarily an inherent structural problem. It is a connective tissue response to stress and strain problem or extracellular
like a
matrix.
degradation issue.
Yeah, so you can have a structural or a functional problem. And I was showing somebody yesterday. I was like, look at all the different like parts of it. There's 20 something different collagen genes. There's not just collagens, but there's laminin, there's the hyaluronic acid, there's all of these different things. It's what like there's so many things that go into stabilizing the extracellular matrix that we don't have all of the information on the components or the polygenic components. Like, okay, well, if you have one of these, and one of these genes, oh gosh, like that's our neurological phenotype. Not yet, but that's what, like, just explaining why this has been so difficult to figure out in people too, is that there is so much to look at, so much.
Sure.
Yep.
So a lot of kind of like a Star Trek, a lot of frontier to explore.
Yeah, I wish I talk about the tricorder with my patients sometimes. I wish we had that Star Trek tricorder. And this is where AI is actually going to be helpful at some point in analyzing like tissue, extracellular matrix, and genetics. And like just boop, boop, boop. Okay, well, you have these underlying risk factors, and I'm sensing this in your tissue, and we need to work on this in this order. And one day it'll be able to tell us the health of connective tissue. And just for those wondering, there is no direct test for the health of the extracellular matrix. It is like we're talking about this interstitial space. It's dynamic and it should be constantly changing. It's when it becomes stiff that it's a problem. So we don't even know what a healthy one should look like. And like we don't really know how to tell, like, where would we do the biopsy? What are we looking at? And things are moving, right? So we don't have a test to look at the health of the matrix yet.
Yeah, so for right now, we're relying on models and understanding of what we think it should be doing.
Conceptual stuff.
Conceptual, yeah.
Mm-hmm.
All right. Well, thanks for redefining connective tissue and connective tissue issues, kind of putting some good framework behind it. I'm sure we'll be back to the ECM plenty.
Oh, plenty. Yeah.
All right. Hey, thanks for tuning in. We look forward to seeing you next time.
Thank you.